Greetings to our colleagues and distinguished guests from around the world. Welcome to this webinar focusing on the healthcare professional's role in the interagency setting at Barnahus, children's advocacy centers, and similar models. We're honored that you've joined us today or are streaming this webinar at a more convenient time of your day. We're delighted to welcome 450 professionals registered from over 80 countries. My name is Gabi Otterman. I'm a child abuse pediatrician at Uppsala University Children's Hospital and affiliated with the Barnahus Center on Violence Against Children at Linköping University in Sweden. I also serve on the board of ISPCAN.
And my name is Kathy Makroff. I'm a child abuse pediatrician at the Meyerson Center for Safe and Healthy Children, a CAC at Cincinnati Children's Hospital in Cincinnati, Ohio, in the United States.
We are co-course directors of the International Course on Child Abuse Pediatrics, INTERCAP. The next INTERCAP will be held in Paris on May 18th to 21st, 2026. This four-day in-person course will bring together leading experts to explore, discuss, and share knowledge on child abuse medicine. Petit refers to a small bite-sized French confection. Today's webinar is just that, a small taste of what to expect in Paris. We'll explore cutting-edge research, evidence-based guidelines, treatment approaches, and prevention strategies focused on the protection and well-being of children. Paris next year will mark our 6th in-person INTERCAP course, starting 10 years ago in Uppsala 2015, Amsterdam 2017, Vienna 2019, Berlin 2022, and Barcelona 2024. I should mention that the course is a nonprofit initiative supported by the American Academy of Pediatrics, host organizations in each country, and ISPCAN. Our faculty and planning committee generously volunteer their time to bring this course to life. We invite you to engage actively in today's webinar and to consider joining us in Paris. It's a unique opportunity to deepen your knowledge, connect with peers, and enhance your practice. So in today's webinar, you're going to hear some references to children's advocacy centers, CACs, and Barnahus. As not everybody might be familiar with these terms, they're two examples of multidisciplinary models that bring professionals together, such as law enforcement or police, child protection, healthcare, and mental health, to respond to child abuse in a coordinated, child-friendly, co-located way. The first CAC was founded in Huntsville, Alabama in the US in 1986. Today, there are over 1,000 CACs in the US and Canada altogether. The Barnahus, which translates literally to children's house in Scandinavian languages, was adapted from this model in Iceland in 1999. Since then, Barnahus has spread, gained traction across Europe and other regions, and we'll hear more about that in today's webinar. While the models may vary, they share the goal of protecting children through interagency collaboration. Health professionals play a pivotal role in this response. Today, we'll hear from 4 leaders in this important work.
Before we begin, a few reminders. There will be a 10-minute break that will follow the second presentation. After the 4 talks, we will have a 15-minute live Q&A session with the speakers. Please place your questions at any time during the webinar into the Q&A box, and we will use these questions during the Q&A session. Please use the chat for private messages, but take a moment to introduce yourself in the chat box. Let us know where you are joining from, your organization, and your discipline. You may enable closed captioning from your Zoom account. You do this by looking for the more and 3-dot option on the bottom panel, and from that, choose captions. A recording of this session will be made available to you and will be available via ISPCAN. Information about this will be sent to you after this session.
Our first presentation is Child and Adolescent Forensic Medical Services for Sexual Harm within a Barnahus model in Ireland, introduced by a short video. Please welcome Dr. Joanne Nelson, consultant pediatrician and clinical director at the Hazel Clinic, Barnahus West in Galway, Ireland. She leads integrated forensic medical services for children within the Barnahus model and brings expertise from her training in the UK and New Zealand, as well as her pioneering work in forensic medicine and interagency child protection in Ireland.
At times, children may need support when something upsetting happens, and it can be hard to know where to find the right help. Barnahus is a safe place where children and young people are respected. Here, they can get the help they need. One of the Barnahus locations in Ireland is in Galway. Barnahus offers child protection, therapy, medical assistance, and criminal investigation under one roof for any child or young person who may have experienced child sexual abuse. The team includes police officers, social workers, doctors, nurses, and therapists who work together to help children feel safe enough to share their stories. Each person on the team is specially trained to make children feel understood and supported, creating a safe space for them to talk about what they've been through. When TUSLA knows that a child has been hurt or made to do uncomfortable things, it is their job to work with children, young people, and their families to make sure they feel safe and looked after. Making sure that the child gets the help they need means talking to the Barnahus team. Once the child is ready to speak with the team, police and social workers bring them in the interview room. One interviewer will remain in the interview room with the child, while the other observes from a room next door. The interviewers are experienced in asking questions and helping young people share their stories in a way that feels comfortable for them. They listen carefully and work to gather the best evidence for the child's investigation. First, it is essential to make the child comfortable, so the interviewers spend time talking about everyday topics like school or hobbies. They explain what will happen and why sharing their story is important, using simple and understandable language. The process moves at the child's pace, and they are in control of what they choose to share. In some cases, the child may need to see a specially trained doctor or nurse. Not every child who comes to Barnahus requires a medical checkup, but when they do, the focus is on checking their health and answering any questions they may have about their body. The benefit of a medical examination is discussed with the family, and they can decide how they wish to proceed. The checkup may also provide important information for the police if needed. Together with the doctors and nurses, they decide whether to proceed, but ultimately the child has the choice to undergo a full, partial, or no examination at all. The child and their caregivers also meet with the Barnahus therapy team to discuss the support they may need. Barnahus therapy is a safe place where a child can talk about things that have happened to them and to make sense of them, as well as work out what might help. It also provides a space for families to talk things through and support them on their road to recovery. Together, they can decide what kind of support is best, whether short-term help at Barnahus or a referral to another support service. Throughout the child's journey at Barnahus, the team works to ensure they feel safe, supported, and informed about what to expect. If a family member needs language assistance, such as an interpreter or sign language support. This is arranged to ensure no one feels left out. Children should always remember that there are people who care and are here to help them. If they have been hurt, scared, or made to do uncomfortable things, it is never their fault. Everyone deserves to feel safe and be respected. At Barnahus, the people are here for the child and family.
Hello, everybody. I'm really pleased to be able to join you today and to participate in this session. It's afternoon in Galway, and I know you're joining from all time zones. So hopefully we can enjoy the shared learning experience. So I'm going to start sharing my slides. I've been already given a lovely introduction by Gabby, and I'm just making sure everybody can see. So I'm Joanne Nelson. I'm a paediatrician in Ireland, based in the west of Ireland in Galway. I'm going to be talking about Barnahus as it applies to the forensic medical side of things for children and young people. And I'm very aware that Ireland is a small country relatively, and you may be working in very much larger areas. But I'd like to share my experience with you of helping to set up a service, the Barnahus service, in a very small country, and the challenges and the advantages and the disadvantages we've faced over time. Ireland has about 5.3 million people, 1.2 million of whom are under the age of 18. And the Barnahus model applies to children under the age of 18. Now, I don't have to tell this informed audience that child sexual abuse is unfortunately very common, but you may be interested to understand the prevalence in Ireland according to our most recent survey on sexual violence in 2022. In this survey, 36% of women reported that they'd experienced child sexual abuse as a child, and 22% of men. Adult sexual assault services in Ireland have been very well established for many years, with the first sexual assault treatment unit, SATU, being set up in the Rotunda in Dublin in 1985. In Ireland, the adult sexual assault services manage children acutely from 14 years up. 14 is a sort of an arbitrary age, bearing in mind that Barnahus manages and supports children from under the age of 18. However, it was a starting point, and we work very much in collaboration. So I've put there the dates of the different services for adults starting in Ireland. And you can see in Galway, which is on the west of Ireland, so the very left red dot is Galway, adult sexual assault services started in 2009. Now, it took to 2011 until the health services within Ireland funded child sexual assault services for children under the age of 14. And now there are three services or three service bases for forensic medical support for children in Ireland. One in Galway, where I work in the west of Ireland, one in Cork, which is in the south of Ireland, and one in the east of Ireland in the major capital city in Dublin. And we support children under the age of 18, but for forensic medical sampling under the age of 14. However, Galway is still the only service in Ireland to offer 24-hour care. That means day or night. There is a facility in Ireland for a child to have an acute forensic medical evaluation if it's required. We do share some of our on-call now with Dublin, who offer a once-a-month support for out-of-hours care, and we're moving towards that this be extended in other areas. I'm sharing with you a map of Ireland, and it's color coded. So you may not be aware that Ireland, when I'm talking about Ireland, refers to Southern Ireland. Northern Ireland is not part of this map. It's up in the right corner and in white, but that's part of the United Kingdom, whereas Southern Ireland is an independent state. The service in Galway, which is one of the blue-coded counties, covers the west and midwest of Ireland. The service in Cork covers the sort of, I think that's green, south of Ireland, and Dublin covers the east. So you can see we are covering a really wide geographical area. For example, a child up in northern Donegal may have to travel 4 or 5 hours by car to reach our service in Galway. That's not ideal. And the Barnahus model is that children shouldn't have to travel long distance to access services, and that services should be equitable. So certainly we're exploring delivery of satellite services more local to children. This is a busy slide just detailing the members of CASAT's Child and Adolescent Sexual Assault Treatment Service, our team. We have the benefit in Galway of being co-located with adult services, and the benefits extend to shared staff. So that means we are 3 consultant paediatricians, each working half-time in the unit, with 1 consultant paediatrician participating in the on-call rota. But we have a team of shared clinical nurse specialists. In Ireland, the clinical nurse specialists are trained to examine adult patients by themselves, and we're working towards enabling the clinical nurse specialists for children to undertake the same P course, which is a qualification, an international qualification, which will enable the nurses to examine pediatric patients for forensic medical evaluation autonomously. There's already 1 advanced nurse practitioner in Dublin working on the on-call rota to this respect. We share administration with our adult SAT2 colleagues. We share a team of on-call out of our support nurses, 16 in number, with our adult colleagues. And we have partnerships with charities such as Rape Crisis Centre and our own paediatric partner charity, ASK, who provide crisis support volunteers accompanying patients at the time of their forensic examination. And now to talk a little bit about Barnahus. So as Gabby has already said, Barnahus is an Icelandic term. Barna meaning child or children, and hus, house. So the concept is that within one house, one office, one space, all the care can be delivered to a child and family without them having to travel to different locations. There are 4 rooms within the Barnahus, and these are pictorially represented. We have a magnifying glass, which is criminal investigation, justice, police. In Ireland, they're called Gardaí. We have a cross, which is representing medical care, forensic medical care, and health needs. The heart is representing safeguarding, and the leaves representing healing, therapeutic support. And all agencies operate under one roof to work towards the 4 rooms. And here we have child protection, forensic medical services, therapeutic supports, and specialist forensic interviewers. In Ireland, there is a move now towards what's called joint specialist interviewing. And that means not only do the police, called the Gardaí, but social workers be trained to undertake specialist forensic interviews for children. What do I mean by that? A specialist forensic interview is effectively the child's statement of evidence. It's a videotaped recording of a child's disclosure of harm, and that will be played to the judge and jury as in a criminal trial. Barnahus in Ireland is part of the Barnahus network in Europe. Now, there are actually 10 quality standards, and if you have interest in this after the talk, please go to the website, the Barnahus Network in Europe, and you can read in greater depths about Barnahus in Europe. But I've summarized them into 5 points. So Barnahus aspires to providing integrated services for all children who are victims of violence. Ireland has chosen to focus on child sexual abuse for the first Barnahus. It may be that in time to come, and I certainly would support this, that this might be extended to other forms of violence, for example, physical injury or neglect or emotional abuse. But at present, the Barnahus in Ireland is focused on child sexual abuse. Children are very much involved in what happens within the Barnahus and the evolution of the service. So children have a right to participate, and we have a child and youth participation group in Barnahus West and listen to the voices of the children. There's a multidisciplinary and interagency collaboration. The aim is to avoid having the child telling their story time and time again, avoiding re-traumatization, and trying to secure improved outcomes in the child's best interest. As I've said, the services should be accessible, comprehensive, and with high professional standards. There are 28 network members in the Barnahus Network of Europe. So that means that each of those countries has Barnahus or a Barnahus type service already in place. And of the remaining 18 states, 5 at the end of 2022 into early 2023 were in the process of setting up such services. So just to illustrate this, and again, this is on the Barnahus Network Europe website, and you can have a look at the map in greater detail, and it will be larger and hopefully more easily seen. But looking at the map of Europe, the blue shading is where European countries where Barnahus is in place. The blue and orange shading, the stripes, are where Barnahus is in place and Barnahus type services are in place. And Ireland, you can see, is shaded in those colours. The orange is where Barnahus type services are in place, and the other colours are variations of Barnahus where interagency working is evolving. And so you can see that Europe is aspiring towards the Barnahus model in almost all of the countries. This map shows the dates at which Barnahus was established in the different countries. So up at the top left, we have Iceland, 1998. The talk that I'm giving from Ireland, 2019. And you can see for the rest of Europe, where there are Barnahus in place, the different dates when the Barnahus were first established. So the ultimate vision in Ireland is that there will be 3 Barnahus centres, one in Cork, one in Dublin, and the one I'm talking about in Galway. So at present, Galway is up, running, fully functional and on site. Barnahus Cork is functioning, but they do not have as yet dedicated premises. Barnahus Dublin is in evolution. It takes departmental, governmental input to get a Barnahus going. And so Barnahus in Ireland is a collaboration between the social work department called the Child and Family Agency, or TUSLA, and Health and Justice. The aim is to support children under the age of 18 who may have experienced sexual abuse. And the secondary target group are the non-offending family members, because to support and enable them is to support the child. In Galway, we started in 2018 as a pilot project. We were launched in 2019, and interagency meetings started towards November 2020. We moved into our premises in January 2022, and you've had the benefit of seeing our premises in the video that was shown before this talk. And this is the aspiration. So On the left, you've got a child who's disclosing sexual harm and a very muddled pathway as she's investigated and spoken to and moved from school to clinic to hospital to a social services department. And she's a very unhappy child, having to disclose her story of sexual trauma time and time again. Nobody talks to each other. Nobody collaborates in a seamless manner. Moving to the right, you see the child disclosing what has happened, being referred into Barnahus, which is a one house with 4 rooms, and having a streamlined support. Now for some facts and figures, please don't be put off. I want you to look at the figure down at the bottom. The number of interagency meetings held since we started meeting in 2020, 367. That means for the number of referrals, which are now over 600, we have met 367 times with our colleagues. So round the table, we have forensic medical staff, we have police, Gardaí, we have social workers, both the safeguarding social workers and the social workers who are dedicated to Barnahus. And we have the therapeutic staff, clinical psychology, the other therapeutic staff who support our children. And if you're thinking of setting up a Barnahus, this, I suppose, is a little warning. We started 2020, and down at the bottom, those are the figures for the new and review cases discussed in the last quarter of 2020. And over time, you can see the numbers escalating, so that up at the top, 2025, in the first quarter, those are the number of new and review cases we have discussed so far this year up until the end of March. Escalating workload needs to be thought about, needs to be planned for. We're busy. This is of interest to people who work in Ireland because it's county specific. But if you look at the bottom of this table, the grand total of referrals to Barnahus since we started in 2020, 658 up until the end of March. And of those, roughly 60, sometimes 68% of children have been offered and received forensic medical examinations. More girls than boys. So you can see almost 3/4 of our patients are female. These are the professionals who refer into forensic medical services. So most of our patients come from the Barnahus interagency meetings, some directly from social workers in the community, and that's likely because they need a more urgent examination, some from the Gardaí, the police, others from healthcare professionals, and then there's a small number who may perhaps have tried to self-refer and with the support of social workers are seen in a timely fashion. Just to remind you of our lovely premises, we're very proud of this, but children played a part in the planning. And this is the reception of the Barnahus, and you'll see that there are no sharp corners. Children don't like corners. They're scared perhaps that a perpetrator will be lurking behind a corner, and so they wanted smooth and rounded corners, surfaces, so that they can't be fearful of somebody hiding in the background. The colours have been chosen to be calming, and the furnishings calming throughout the unit. This is our therapeutic space, geared to be child-friendly. The toys are beaded and weighted. There's a sensory element. Our Barnahus manager is an occupational therapist by background and focused on sensory integration. And this is the forensic medical room with a dedicated child couch for the young children, the prepubertal children, with a weighing and measuring scales and cupboards that the children like to climb in and out of. We try and make it as child-friendly as possible. I thought it would be helpful to think about a case. So I'm going to take you through the case of Timmy, who is a very sad little boy, depicted in cartoon form here. So let's imagine Timmy presents to services. He's 5. He told his parents last night that Uncle Jimmy, who is Mum's sister's partner, put a stick in his bum and it was sore. He was very upset. The parents are very upset. They're really alarmed that Timmy may have been sexually harmed. However, they know he's well. They know that last contact with Uncle Jimmy was some time past. And so they send Timmy to school and they present to their local police station, to the Gardaí. And they say, we're really worried, our son has been sexually abused. We just don't know where to go. So there's various things that need to be thought about for Timmy. In Ireland, we have national guidelines on forensic examination, which cover all ages. And there's a dedicated chapter for children and adolescents. And so we refer to the guidelines. But we really need to think about Timmy's safety. So is Timmy safe? So the Gardaí will automatically link in with a community social work team called TUSLA, who deal with safeguarding, and they will check with the child and his parents that he is indeed safe. And then as part of the evaluation, we need to think of urgent health and forensic needs. So does Timmy have any symptoms? Is he bleeding? When was the last contact with this man? Does he need an urgent forensic examination with forensic sampling? Might he have a sexually transmitted infection? Do we need to think along those lines? And so at this point, there should be liaison with forensic medical services to explore whether anything urgent is needed to this respect. Does he need an acute forensic medical examination? And so we think of timeframes. And so we know that the forensic window for forensic sampling is very short in a prepubertal child. So we've got about 72 hours between time of last sexual contact and the examination to collect forensic evidence. Obviously, those timeframes are longer for older children. And in Ireland, we have a policy where we examine children within 1 working day if they present within 34 days of last potential sexual contact to look for healing injuries that may be in the process of healing, if indeed there are any. And we do know that most examinations will be normal. We're also taking on board whether there may be any need for perhaps HIV post-exposure prophylaxis, or in an adolescent girl, emergency contraception. And we're thinking about the child's anxiety, the caregiver's anxiety, and the need for the therapeutic benefit of knowing their child is well. So all of these things will guide the need for urgent examination or otherwise. A pediatric forensic examination will cover all of this. So of course we do a clinical history examination, we do detailed documentation, including body diagrams, we take pictures of the intimate examination, we can get Gardaí police to take pictures of the non-intimate injuries, we take forensic samples, medical samples for sexually transmitted infection, coordinate any urgent treatment, write a report, and arrange necessary aftercare. Looking at forensic needs, looking at health and psychology, looking at safeguarding. However, in this case, Timmy hasn't seen his Uncle Jimmy for over 6 weeks, and so he's well. There isn't a need for an acute forensic medical examination. This is a non-acute case, and so in a timely fashion, within 5 days, his case is brought to an interagency planning meeting, and round the table sit all professionals who can decide which agency engages and what happens next. And this might be Timmy's journey through the Barnahus. This is a non-acute examination. So the child protection social worker has established Timmy's safety. There's an interagency referrals meeting where all information is shared. It may be that a joint forensic interview will be planned first and forensic medical examination after. And then there may be onward referrals and therapeutic assessment and intervention. It's a seamless and streamlined journey. So what have been the challenges to Barnahus in Ireland? Well, there are challenges, as with any new services, some resistance to change, some challenges encouraging people to make referrals. We're worried about the distance our patients have to travel. At the moment in Ireland, there are delays to the forensic interviews, and this can potentially delay medical examination, although we have capacity to examine children quickly if it's in their best interest. I've shown you some of our data. The numbers are escalating. We're very busy. It's very time intensive to sit around the table and talk with other agencies, although much information is shared, and that's really useful. And there's a nervousness about sharing intervention. Can we trust the different agencies? Do they respect our data as much as their own? We have an escalating need for administrative support. We have challenges with different governance structures. For example, the Gardaí have one governance structure. In health, we have a different governance structure. Social workers have a different governance structure altogether, and resistance to change. I looked up the challenges with interagency working after I'd thought about it myself. So here AI comes into effect, and indeed we have faced all of these advantages and disadvantages. But the benefits far outweigh the disadvantages. Our goal is that every child is in a better position when the process ends than when it began. Thank you very much for your time and interest. I'll be delighted to take questions at the end of the presentations, and thank you for joining.
Thank you so much, Joanne. That was a wonderful presentation to start us off. And just a reminder, I see that there are some questions already in the Q&A tab. Please place your question at any time for any speaker during the webinar. Our next talk is Normal to be Normal in Child Sexual Abuse. Please welcome Dr. Karen Farst. Dr. Farst has worked as a child abuse pediatrician with the Team for Children at Risk at Arkansas Children's Hospital since 2004. She is currently a professor of pediatrics with the Department of Pediatrics of the University of Arkansas for Medical Sciences and chief medical officer for Arkansas Children's Hospital in the United States.
Good morning from Arkansas, even though I realize it may not be morning for many of you wherever you are, and what an honor to join this group and to be presenting. And thank you to Joanne for a great lead-off presentation. I'm going to springboard from some of the things that Joanne presented and really spend time talking more about one of the challenges that I think we face, really, whether it's within our societal understanding of child sexual abuse, within our investigator conversations, as well as in our judicial or our legal forums, as far as why there are often no physical or evidentiary findings when we do the medical evaluation for child sexual abuse. And I also just want to share a little bit of background because this is my first endeavor to hear more about how the Barnahus model has spread, and the Children's Advocacy Center model in the United States was really my springboard into following child abuse pediatrics as a career. My residency training was in primary care for pediatrics and internal medicine, and I was in private practice thinking that's what I would do the rest of my life when I became involved as a volunteer medical provider at our local community Children's Advocacy Center. And it was really through those experiences that I decided that I really wanted to be involved in child abuse pediatrics as a career. So this opportunity to speak to this group and about this topic is really something that is just a pleasure, because this has been my career, and something that has really been a challenge in a lot of ways, but also I've met just some amazing people, and had a chance to be involved in a growing field that I think we're not all the way there, but we are certainly doing better. And again, just to see how the Barnahus model has taken root is it's just very encouraging to me. So for the next 25 minutes or so, I will dive into, you will hear me say normal to be normal several times. We'll explain really how that phrase kind of came to be, and talk some about just the practical explanations of why this is something that is accepted. But then we'll also take a bit of a dive into the evidence base as well. I'll warn you that I do have some wordy slides, but I am not going to read every single slide to you. These slides will be made available to people in a PDF format, so you will have access to the slides and the information if you want to do a deeper dive. And I'm going to just touch briefly at the end about disclosure dynamics, not from the aspect of being a forensic interviewer or an investigator, but more from the part of how disclosure dynamics tie into the fact that we are oftentimes not seeing children within that very acute time frame to be able to either collect DNA evidence, or to be able to see especially minor types of injuries that can go away within a 24-hour period. So again, I'm not going to try to step on toes of colleagues who are in mental health or investigator roles, but I do think there is a place for not only the understanding, but the application of the disclosure dynamics for a medical provider as well. And again, this audience, I know that just from looking through the different participants on the list, I know this is already a very knowledgeable audience, but I do just want to set the stage that as we're talking about child sexual abuse, I'm talking more about the group of patients or victims that we would see where that dynamic that the offender is typically known to the child is the case. When we talk about more stranger assault or adult sexual assault, I do just want to make a distinction between those two groups. Now, there is not a firm line that delineates these two groups, but as we're talking just for context this morning, I do want to talk about this group of patients that we encounter where typically the process of child sexual abuse is happening over a period of time, and there has been typically some relationship building with somebody known to the child leading up to that, and that is a big part of the delay and disclosure process that we'll talk about as well. So Joanne just already did a very nice job of really talking about kind of how the medical exam fits into the evaluation when there's been a concern or a disclosure of sexual abuse. When the medical exam is all said and done, and that could be whether or not we were within a period of time where biologic evidence was collected or not, or whether there was testing for sexually transmitted infections, usually the medical exam will come down to whether there were physical findings that were conclusive that there had been some type of trauma relating to a penetrating event to the genitals or to the anal area. And then there may also be ancillary information from whether there was evidence collection or STI testing done. We're not going to go through necessarily the details about how to do an exam. I'm assuming this is a mixed audience. I will provide some references for you that if you want to go into a deeper dive on interpreting the actual findings. But actually, in the majority of cases, the medical provider is going to be saying that there were no conclusive findings, meaning the exam was basically normal for that child's developmental age and stage. If there are findings, and I won't spend a ton of time on this because the focus is about a normal exam, but if there is evidence of trauma, so say there is a healed transection to the hymen, we aren't able to say from a medical standpoint the object that caused the trauma, if it is already healed, how long has it been healed, or whether it was a consensual or non-consensual event, if it was a scenario of someone that had the age and the capacity to consent. The flip to that is true, that if there is no evidence, if there are not healed injuries or acute trauma, it doesn't at all mean that sexual abuse is ruled out. It does not mean that the child is not telling the truth. And it also does not mean that there is no chance to develop an infection or pregnancy related to sexual abuse. So for sexually transmitted infections, or STIs, that could be a totally separate talk, and I'm not going to do a deep dive into that today. But what we are typically testing for, when in child sexual abuse cases, would be more common STIs like gonorrhea, chlamydia, trichomonas. We could also do blood testing for things like HIV. So if an STI has been confirmed, it is oftentimes very difficult, again, just from the medical evidence. This is where we have to be a team and rely on other information and history taking. But we aren't able, really, just from a medical standpoint, to be able to say the timing of when that STI was obtained. We may be able to get some help from review of the child's past medical records, depending on what type of medical treatment they've had up to that point. It is also very, very difficult to match the person that passed the infection to the patient. Again, sometimes history and our investigation can give us some helpful information, but it can also, can obviously be corroborative. If in Joanne's example, if Timmy tested positive for an STI and that person that Timmy disclosed had been the offender also tests positive for that STI, that's definitely collaborative, corroborative information, but it's not necessarily something that we would be able to say that was like a DNA link of that person being the offender. The opposite of that is true, that if an alleged offender is negative and the patient has an infection, it does not necessarily mean that that person is not the offender or the perpetrator. You can clear most STDs. You could clear that if you have a healthy immune system. That would not be true for things like HIV or things that you would have to have treatment or have viral signal from longer term. And you can also go some places to get treatment anonymously. And so by the time the offender gets tested, it may mean that their infection is already cleared. And then the flip to that is true. Thankfully, it's not a one-to-one situation where every time somebody has contact with somebody that they pass an STI. But these can be really difficult things to talk through from a team standpoint, and they do really require just that, as Joanne was talking about, sitting down and really going through the case and talking about the information that everybody has to try to get to that point of understanding the timeline of what's occurred. So we're going to jump into some of the literature and just more of the challenges in that discussion of talking about why there are not usually physical findings to go along with. I'll refer several times to what has kind of become known in the field as the Adams guidelines. There's a series of articles, and I'll show you or kind of walk you through those briefly and let you know kind of how that came to be. Joyce Adams is a pediatric gynecologist that practiced in California. She has retired in the last few years, but is still out there and working on the literature base. But she wrote the original article in 1994 that said it was normal to be normal. So there you go. That's where that catchphrase really came from. And she had looked at 236 children who had a perpetrator conviction for sexual abuse. Now, in this and in our earlier literature, those studies were oftentimes not including a non-abuse comparison group. But even with that, these children that were examined, there were no kind of just obvious findings of, again, like a heel transection to the hymen or some type of scar that somebody could relate to being from a sexual abuse event. But so this was really 1994 was kind of the birth of that phrase and this concept. And so I don't think that is, it's not a surprise to people that was something that came a little bit as unexpected. So wherever you work in the world, I know we have many countries represented on this webinar, that I think if you just asked most people who weren't involved in the field, would you expect, if you did a detailed medical exam on a child who says that they've been sexually abused, especially abused with penetration, abused multiple times, should there be physical findings? And the majority of people would probably say yes. And there is actually even an article out there that did ask that question of, when children are sexually abused, would you expect that there's usually going to be physical evidence? And 72% of the participants, these were not medical people, said yes. And so that is really the framework when we talk with a family of a child that has disclosed abuse, when we talk to investigators, and certainly when we go into the courtroom settings, that this is something that we have to know is the baseline of what people would expect. And to me, this is the whole really kind of focus or premise behind the CACs and Barnahus, is that we actually, it's not easy to physically prove that sexual abuse has occurred. And so to do a very well done forensic interview, a corroborative investigation, share information to really get to the truth of what's happened, it takes so much more than what we might just think of if we didn't have our knowledge and background of just being able to say, oh, we'll just let them go have a checkup or do one of those DNA tests and we'll find out. And this is really, again, the strength of that team-based approach from the CAC or the Barnahus model. So I'm going to start just with kind of the way, from a practical standpoint, of how I've come to explain this to families, and then the investigator process just over time. I've definitely worked on this over time and have learned a lot about how to explain it just by feedback and people that say, I just still don't believe you. I still think there has to be findings there. And so when we think about, especially, we're focusing on really the anal and genital area of boys and girls. So that type of skin is mucosal skin. So different than what we would think of kind of as our typical outside dermal skin. And when I've explained it to people before, I've said it's that same skin that's on the inside of your mouth. It's very stretchy, very elastic, so it can actually accommodate quite a bit without having a tear. But if it does get a tear to it, it typically heals quickly. And most people can think about when they bit on the inside of their mouth that they may have had kind of a rough and rugged area, but then it heals quickly. For those of you in medicine, it's unusual that we have to do stitching to mucosal skin because it does typically come back and approximate well, and it doesn't form the same type of visible scarring that kind of our other usual external skin that we would expect it to. So number one, a lot can happen without even leaving any kind of injury behind. Number two, as we've alluded to and we'll spend some time at the end talking about, we oftentimes aren't seeing children right after the event has occurred. We are seeing them usually a couple of weeks, a couple of months, even a couple of years later. So things that were present can definitely go away quickly. If we see somebody even right when something has occurred and then see an injury and follow them back within even a few days, superficial injuries like scratches and petechiae will go away from the mucosal skin in a matter of days. Deeper cuts that are bleeding maybe takes them a couple of weeks, but at the same time, if I didn't see that initial injury and I see them 2 weeks later, it can be very difficult to know that there was something that caused bleeding even within 2 weeks of when the event happened. The last point on here about the type of contact and how children describe penetration, to me, is maybe one of the biggest things that I think folks have a hard time letting go of their adult understanding of sex and trying to think of sexual contact through the mind of a child, especially if it's a child that has not yet initiated their own consensual sexual activity. So that meaning of penetration, and I'll speak more specifically about girls in the genital area, that the what penetration would mean as far as something, whether something was in or not, is usually being described as a feeling or a sensation. They don't necessarily have the understanding of, well, my labia majora or the thing is what's protecting kind of the outer part of my genitalia. And then when you touch past the labia majora, there might be some pressure in that area, but then you have to actually go very deep in past that to get to the hymen, which is the beginning of the vaginal canal, to really start to describe something that a younger child would say, yeah, that was really painful and hurt. When we hear something went in from an adult standpoint, we automatically think of vaginal penetration. And some of that gets to just how we describe that part of our body, because many people describe everything down there from a female standpoint as the vagina. And that's not necessarily true. Um, the so the and you'll excuse maybe some of my crude analogies at the bottom of the screen, but when you can think about the labia majora as like a hot dog bun, and you can think of the hot dog or the sausage in the middle going back and forth in the bun, that is oftentimes the contact that's occurring in child sexual abuse, because the offender wants to do something that they get the sexual pleasure from, but it doesn't necessarily cause bleeding, tearing injury to the child because they want to continue that relationship. And so that type of back and forth motion, the child feels that and can describe it when they have a forensic interview, but it's not necessarily the hot dog turned on its end, piercing through the bun. And so again, apologies for the analogy if you like hot dogs or sausages, but it is something for people to really understand when they're hearing a child describe the type of contact, that they may not be describing what our concept of sexual intercourse is. The scrunchie or the hairband in the middle of the picture is really meant to just to demonstrate the stretchiness or the accommodation of the hymen. I think a lot of people think that the hymen is like the green glass bottle, that it's a rigid structure that if you could measure across there, that nothing bigger than that could go past the hymen without tearing it. And the truth is that the hymen is very stretchy and elastic, and it can accommodate to be able to allow penetration without tearing. We see that when we have young children come in with foreign bodies, if they have stuck something up there that they shouldn't have. When we have them sedated and relaxed, we can actually get a speculum past the hymen, retrieve a foreign body, and we don't tear anything in the midst of that. And so these are concepts that obviously people who aren't in this field don't think about on a regular basis, and it takes time to describe this, and it oftentimes takes putting it into whatever makes sense for you from a practical standpoint, so that people can understand, again, especially in younger children, that the sensations and what people are describing is not necessarily our adult understanding of sex. The other thing that is really important to understand, again, for younger children, that when pre-pubertal girls are describing contact, the hymen itself is very, very sensitive to touch until they get estrogenized. When estrogen starts to circulate and takes the girls into puberty, then the hymen becomes less sensitive to touch, becomes more full. And so if a young girl, 5, 6, 7-year-old, says, yes, it went in and it hurt, they are saying that something went past the labia majora and came in contact with the hymen, but they're not necessarily saying that something went into the vagina itself. And so as you're doing or hearing a forensic interview and you hear those types of things described, it can help you understand what the child is describing. As a medical provider, when I do an exam on a pre-pubertal girl, I have to be careful not to touch the hymen if I'm doing Q-tips or something like that, because it'll be painful. And so again, as we then start to try to describe this to other people, and especially in the courtroom setting, being able to describe what the patient has described as symptoms to what their disclosure is, this can actually help it make more sense to people if we take the time to really help people understand some of those different dynamics. I'm taking for granted that people in different countries will understand the TV show of Crime Scene Investigation, or CSI. So in this TV show, you can watch it for an hour, and from the beginning to the end, they will have every crime solved with every piece of evidence that you could imagine, and everything wraps up into a nice little bow. And we have that expectation quite a bit of times from juries or even our investigator colleagues that they really don't think that this type of event could occur without the medical people being able to find evidence that it has occurred. And so again, it's a challenge that the majority of the time, I think it is very important that we do a good job with these exams up front, because if we do have DNA evidence or we do identify an injury, it certainly can help the process make more sense. But the majority of the time, as we've talked about, we don't have those types of findings. And so it's just as important for us to be able to explain this so that people who are hearing the disclosure from the child don't turn off listening to the child, and they will still work through the investigation and the safety and the aftercare that's needed for a child. So expect it that you will have people that want to know that CSI response. I will oftentimes have, if I'm in court especially, have the prosecuting attorney ask me how we do the exam. Not that it's important for the jury, but I want to be able to explain, again, especially in a girl's exam, I want to be able to explain the three-dimensionality or the depth of labia majora are external, and then you get past the labia majora and have some depth before you actually get to where the vagina starts and the hymen is there. And I am a fan of using some visual aids. I try to resist having the child's actual pictures entered into court. Every jurisdiction has kind of their own rules on that. But I will try to suggest using some kind of diagram or even just try to draw freehand, so that, again, the people that are trying to get to the point of saying, I can understand how this child's disclosure happened, even though there's not physical evidence. I want them to be able to get to that point. It's obviously a balance that we don't want to overwhelm them with medical things, but this diagram from the article that's referenced is able to really show some of that depth that we're talking about before you go from labia majora to hymen to then into the vagina. Another one is just one that you can put this together on PowerPoint, just so that people understand where the different openings are and what you're talking about from a medical standpoint if you're in a courtroom or even just a team-based type of setting. So here come some of the wordy slides. And again, I am not going to read all of these to you, but if you are interested in knowing kind of how we evolved, that very initial article that we talked about, Normal to be Normal, from 1994, kind of launched into the research field for this. So there was a couple of hallmark articles in 2002. Astrid Hager's article, which I'll talk about in just a minute, looked at a much bigger N. So there was a couple of thousand children in Dr. Hager's study compared to just a few hundred in Dr. Adams' initial study. But then Abby Berenson, another gynecologist, she did a series of articles in 2002 that actually was, to me, one of the most helpful things in our field, because she put in this non-abuse case control kind of cohort. So she compared kids as they kind of went through puberty for kids that did not have a history of abuse or trauma to their anal genital area, and then kids that did. And that really, to me, helped us understand what findings on an exam were actually significant to a history of trauma and what are just things that are just normal variants, because we all develop differently. And then from that, as the research base really kind of grew from there, there were several articles that Dr. Adams put together that she set up a really kind of a guideline or an interpretation table as far as which findings were known to occur just across different kids as just non-specific variants, no relationship to having a history of trauma. And then which ones were really only described in kids with trauma. And then there was this group in the middle that has been called either indeterminate or inconclusive over time. So you can see through the dates that has been updated about every 5 years, looking into the literature, kind of updating the findings. And then I think our most recent one, and I'll show you the reference here in just a little bit, is from 2023. And I'm going to just go through these really quickly. The Hager article, like I talked about, had a couple of thousand kids. This was to me one of the first just large N sizes, and this was really, I think, even if you had said originally, well, I could see where this could happen, but I don't really see that it would be the norm. But Dr. Hager, when she was looking at these, found that, again, when you looked at even the severe cases of alleged penetration, only 6% of girls and 1% of males had conclusive abnormal medical findings. And so this was really the information that started to get out there to say, this is actually really common, that kids can have a sexual abuse event and not have definitive findings. Similar to Hager, there was a more recent article by Smith that looked at 3,500 patients. And again, it was definitely the norm that people did not have any conclusive findings of trauma. And you have to, when you look back at these articles, know that, like for the Smith article, they were using the classification scheme from Joyce Adams from 2007. And that classification scheme of findings has actually become more narrow even since this. And so as you look over time, there's actually less and less that's truly conclusive about healed injuries from abuse, and important for us to be able to, again, continue to be advocates for folks really listening to the child and understanding the truth of the disclosure that's there. The next few slides, again, mostly for your reference, but we've had several kind of spring off studies that even in kids who are pregnant, so not necessarily kids, adolescents. So even if you were pregnant, which would be proof of penetration, only 5% of teenagers in this study had conclusive findings of injury. If there's an acute assault. So I think a lot of times the attack is, well, you're diluting your study because you're looking at people that had non-acute and acute exams. But so if you narrow it down even to just acute assault, the number is higher, but it's still only 20% that had conclusive findings of anal genital trauma. What about if there's a sexually transmitted infection present? That should indicate that there was very intimate contact that occurred. And again, even in looking at a group of young kids with STIs, so this has a very high pretest probability for sexual abuse, it was still the norm to have no specific findings. Other folks have said, well, for older kids, then maybe they have already had sexual activity, and so that makes them less likely to have findings that are there. But so this was a study that looked at the rates of abnormal findings for people who had never had sex versus those that had sex. And again, it was a little more common to have findings in the group that had never had sex, but it was not the norm at all. Another study looking at the difference in consensual and non-consensual encounters. And then even with multiple episodes of abuse, this was an article by Jim Anders, who's now in Kansas City, and looked at children who had described multiple evidence, up to more than 10 events of penetrating trauma. And again, they did not have specific or conclusive findings of trauma. There was a really nice follow-up article to this by Gallion, who went a step further and asked kids to actually describe when, and this again was girls, when you're wiping after you go to the bathroom, do you wipe inside, outside, or something else? And so even when you ask the child themselves, they are oftentimes describing, if you wipe between the labia majora, some of those children are describing that that's inside. Some are saying that's outside because it's not all the way up in the vagina. And some are saying both. So even from the child standpoint, it's not consistent to say that just because somebody says inside, it doesn't mean they're saying that something went past their labia majora and all the way into the vagina. So the most recent kind of review off of this, if you're looking for the article that's kind of the most recent, is from Child Abuse and Neglect in 2023. I also want to give a shout out to colleagues in Germany and Greece who have a very nice review in the Journal of Clinical Medicine that was published just last year. So if you're looking for kind of maybe the most recent articles, I would refer you to these for just kind of a summary of what we've been talking about. The thing that remains a conundrum or a challenge from the medical standpoint is what to do with notches. So a notch in the hymen just means that the hymen is not a perfect kind of donut ring. We know that the superficial notches are just things that happen over time, that's just a normal variant. And we know that a transection or a missing segment of the hymen, when it's in the posterior or bottom rim of the hymen, has really only been described when there's been a penetrating trauma. We still struggle with what to do with deep notches, so a notch that goes maybe almost to the base of the hymen, but not all the way there. And that's why these are in the classification scheme in the inconclusive group, because we really just aren't sure if that is indicative that there has been prior injury, or if it is a way that the hymen can just develop over time as it estrogenizes. So, but it really gets back to those were a lot of articles just to run through. And again, you are welcome to go back and kind of take a deeper dive on those. But it really, to me, from a medical standpoint, gets back to being able to explain this in your own terms. Oftentimes, families or juries will kind of glaze over when we start to talk about the evidence base, and they really want to hear more of the practical information. And the flip to this that Kathy mentioned at the beginning is that we do feel some pushback of saying, well, if most of the exams are normal, why do we do them? Should we be doing fewer exams? And again, Joanne did a great job of talking about kind of the urgent and non-urgent criteria and why the exams are still beneficial. But I do think that medical providers should take ownership of advocating for exams, because there is more to this. The disclosure is a process. Sometimes we don't hear everything on the first disclosure, and we do have an opportunity from a medical standpoint to address poor body image or self-blame. One of the, I hate to say favorite, because it's never a fun thing to do an exam on a child who's disclosed sexual abuse, but it is one of my favorite things to be able to look at a child afterwards and say, I am so sorry that something bad has happened to you, but it is really important for you to know that your body is totally normal and you look just like you should for somebody your age. You can just see the weight kind of fall off of people's shoulders when you're able to have that conversation with them. So I know that there are jurisdictional differences and payment differences for how we can do exams, but it is still my bias to try to offer that exam, even if it's an exam we don't expect evidence from. And like I said, just from the closing start part of this, just a few more references for you. I see disclosure dynamics used to attack a child's disclosure. So if this was really something that happened, if it was that bad, why did they wait to tell? They just made it up afterwards. And a parent may say, if it's really happened, they would have told me, when in actuality, the parents are oftentimes the last person that the child wants to tell because they don't want to hurt their feelings or feel like they might get in trouble. So just a few more references on delay and disclosure. This is an old article from the February 2000, but it has, to me, some really good information, because this was a telephone interview of over 3,000 adults, and they asked them to describe childhood rape experiences. And you can see on the side the different times that people disclose. So less than 25% of the time, it was within a day. About 30% of the time, it was 1 to 6 months. But look at that light peach area where it was more than 5 years. And 28% of that group, this telephone survey was the first time they had ever disclosed. So when you talk about that normality of delay in disclosure and why we don't oftentimes see kids in a timely manner to be able to either collect evidence or see some of the superficial injuries that go away, this is as normal as what we talked about as far as how things heal so quickly and why there's not oftentimes physical injury there. So again, just a few more. This is, I think, probably very common sense to this audience because you are used to the dynamics that happen in this field. But knowing that the relationship with the perpetrator, the fears that the child may have been told by the perpetrator as far as getting in trouble or having people think it was their fault, all these different types of dynamics that are actually very effective to use on children to keep them from delaying and disclosing are very well established now in our literature. And so even if somebody can't kind of put themselves in the position of a child and think, it would actually be pretty hard to say that my coach, who is this very well-known person in the community, has been taking advantage of me. This is something that there's really, it's kind of incontrovertible in the literature if you're needing to take that into a courtroom setting. The self-blame part of this is another big thing that as a medical provider, I like to try to address with children who are old enough to have that conversation with me, because just because something bad happened to them does not make them a bad person. And I see so many kids, and I'm sure this audience is aware of too, that this sets them up for such high risk behavior as far as eating disorders and self-harm and all of the things that we know that the toxic stress and adverse childhood experience cascade can result in for these children. And then the last point is just on recantation, just another article to show that from a child that discloses and then recants, that's obviously used quite a bit of times to try to deflect from the initial disclosure and the fact that could be true. Somewhat, common sense again for this audience would be to say, if you aren't believed by your family members or you disclose and your family is like, why did you do that? You just now have ruined our family. That a child is going to try to protect their family and reel that back in and recant, which would be a normal expectation. And so the fact that they recant really shouldn't be used to tear them down. It's really something that just shows that they need that support. So I know we went through a lot of information and a lot of references to the evidence base. And so these slides will be available to you, and that the article that was the most recent one by Kellogg will be provided to you with your slides as well. And again, I just thank you very much for joining and being a part of this, but also just thank you very much for the work that you do. I was looking at all the different introductions, and we have just such an amazing group of people online. So thank you all for the work that you do. And I will hand it back to Dr. Makaroff.
So thank you so much, Dr. Farce. You're getting lots of accolades down there coming up. It is time for a 10-minute break. I have 20 after the hour, or 50 after the hour for some people. So we will be returning in 10 minutes, so either half past or at the top of the hour for you. We will be stopping the recording right now and starting it up again. Just to
our next talk is the intervention of the psychologist in the evaluation within the Barnahus model. This is a pre-recorded presentation by Dr. Valérie Benoit, a clinical psychologist at the Unité d'accueil pédiatrique enfants en danger, UAPED, or pediatric reception units for children at risk in Orléans, France. Dr. Benoit earned a degree in clinical psychopathology from the University of Toulouse. She has worked extensively with minors and families in child protection settings, including prisons, schools, and the judicial system. Since 2013, she has been part of the multidisciplinary team at UAPED Orléans, and As she is not available for the live question and answer, please include your email with your questions if you do have questions to Dr. Benoit in the Q&A tab, so that we can follow up with a response. You will also be provided her email address. Thank you.
Hello, I am Valérie Benoit, psychologist at the UAPED of Orléans, which is the equivalent of Barnahus centers and expert psychologist near the Court of Appeal of Orléans. I will first introduce you to the work of psychologists in this unit, and first introduce you to the team that makes up this unit. First of all, we have the medical team, which is composed of 2 forensic pediatricians. At this time, we welcome 2 junior forensic doctors. The doctors are assisted by 2 nurses who will be the common thread with the child throughout his presence in our unit. In the team, there are also 2 social workers, 4 psychologists, 3 secretaries, 1 manager, and Orko, a legal assistant staff. I will now present you the organization of the work of psychologists in the Barnahus Center. The UAPED has 2 departments, 1 medical legal unit for minors and a day hospital. The same team intervenes on these 2 units. What differentiates these 2 units is, well, on the one hand, at the UMG minors, we welcome children on requisitions only following a complaint or a report to the prosecutor of the Republic. Requisitions are either medical, psychological, or both. So we're in a judicial investigation at the very beginning of this investigation. We receive the child as a psychologist in order to assess the psychological impact of the events she has experienced. In the day hospital, children are not received as part of an investigation. There is no investigation yet, there is no requisition. They are received when there is a suspicion, a concern, which may be on the part of a relative, a parent, or even a caregiver. Why are we talking about a multidisciplinary assessment? Because in the same place, at the same time, the child will meet several professionals, a nurse, a doctor, a psychologist, and when it is a situation of domestic abuse, a social worker will collect the necessary information about his life context. So everyone will do what he knows how to do, his work, and the nurse will stay by his side throughout his journey. She will be his red thread. She explains everything that is going to happen and collects his questions. The nurse is also in the observation of her attitudes and interactions with the relatives who accompany her, including the relational dynamics with her parents. The nurse also attends the medical examination. She is not present during the psychological interview. The more exact setting of this collection of the child's speech. You see on the left side of the screen the film audition room. At the top is a technical room where you can see the registration terminal and the one-way mirror. Below the hearing room, where the child settles down and where Orko, the judicial assistant's dog, awaits him, the only caregiver who can be present in the room at the same time as the investigator during the hearing. All the professionals involved in this assessment sit in the technical room and listen to the child. The child knows that they are there, behind the two-way mirror, that we will listen to everything she has to say. The psychologist will, of course, take notes of the verbatim of the child, but also pay attention to his behavior, his attitudes. It can be sometimes tears or moments of discomfort. The 3 middle photos is our waiting room where the child is installed by the nurse. A little playful moment of exchange is proposed and Orko is finally presented. And finally, the last photo is in the office of psychologists where the psychological impact assessment interview takes place. Sometimes there may not be a filmed audition in our unit. In these cases, the investigator who conducted the hearing at his own premises sends us the minutes of the hearing. At this point, we give the child a summary of what we have understood, and he has the right to correct our understanding if we have misunderstood, which may allow him or her to provide details, modify, or possibly disprove his or her words. The assessment is mainly carried out with the interview. There is no psychometric test or evaluation scale. On the other hand, in this interview, there is a search for significant signs of psychological impact. Why work in multi-partnership? Because there are several agreements that have been signed. The first, the Justice, Gendarme, Hospital Convention. This is what we call the Permanence Gendarme Convention, which began in 2023 with 2 days a week, knowing that we are now at 4 days a week. Friday is reserved for emergencies. It was the opportunity to strengthen an existing partnership with investigators, but also improve the care of children and optimize emergencies in particular, and even simply the course of the beginning of the investigation. This convention avoids the repetition of the child's word, and the judicial police officer who conducts the hearing is trained in the NICHT protocol that promotes the release of speech and respect for recollection without being too impacting for the child. In the first time, with this gendarme we meet, without the child, only between professionals, to share our mutual information on the situation. The child may have already been hospitalized in our facility or heard in our unit for similar or other facts. In a second time, there is a film audition, or only the policeman and Orco enters the audition room with the child. At one point, the police officer comes and talks with the other professionals involved in this requisition, which are namely the physician and or psychologist. At the end of this hearing, there is a psychological examination and then a medical examination. Normally, it happens in this order, except for teenagers, because the medical examination often comes to mobilize the attention of the young person and can make him or her less psychologically available for the interview. So this is the only situation where the psychologist sees the teenager after the medical examination. And finally, the writing of an examination report to answer questions asked by the investigator. The second agreement signed between the justice, firefighter, gendarmerie, hospital is for children witnesses of homicide or attempted homicide, where there is a care of children following a homicide or deliberate violence that has resulted in the death or hospitalization of the person in a vital emergency of a parent or member of the family unit. I refer here to the shaken baby, where parents can be potentially implicated, for example. Instead, the placement of children, a provisional placement order may be requested by the Attorney of the Republic to provide for a hospitalization of 72 hours, which allows an assessment of child welfare to find resource persons in the child environment and to avoid placement that could amplify the trauma. Finally, the third agreement between justice, the hospital, and the association Handicien, which is the association that forms the legal assistant dog. You see several photos where Orco was able to work at the same time during the psychological interview, including the top photo where Orco wears glasses. You also have the bottom photo during a medical examination, and the other photos are during the film audition in the auditory room itself. Orco's role is to come and appease the child. Orco is introduced to the child maybe after his arrival in the unit, and he does not leave it for almost all of his presence at UAPED. Finally, I would like to talk about the tools we use in clinical management. In the time of care, which is not carried out by the same psychologist who conducted the assessment, but another psychologist from the unit trained in psychotrauma. In Orléans precisely, we will work with reinsurance technology, stabilization, and anchoring technology. I am the only one who is trained in EMDR protocols, and I have used the recent Stevens EMDR protocol, which is called GTEP. We also offer psychoeducation to parents on trauma in order to anticipate a delayed emergence of symptomatology. The children are received between 5 and 10 appointments, and then we orient them. I was talking about earlier, here is the cardiac coherence that can be used as stabilization tools, but also the GTEP. There you have a blank sheet on one field with words or drawing. Only positive verbatim is verbalized. Negative thoughts are transcribed into drawings or words without being otherwise named. Until then, I mentioned that what was happening at Orléans. Now, I will present you what is happening at the UAPED of Clermont-Ferrand, where they have created a tool called NATI. It's not a tool that we don't use yet, but it's very interesting and very original. As you can see, it is a large carpet where the entire course of the procedure, the child with the various stakeholders, is taken. I am now going to read their presentation. NATI illustrates and facilitates explanations for child victims and their family. The main objective is to promote understanding of the interactions between the various stakeholders involved in the protection and care of a minor victim. 4 themes are covered. Family, to talk about the environment. Care, to identify resource organizations. French legal proceedings, in order to understand the different phases of the process and the roles of the various professionals. And finally, social educational intervention, to gain insight of the social educational component. NATI is also used in professional training. It's essential for professionals to consider the needs and resources of child victims and their families, but also children's different levels of development and understanding, and children's rhythm and their questions. NATI encourages discussions and interactions between professionals and children. NATI is presented in a box with the educational board, ergonomic, washable, and easily transportable, 155 explanatory cards, and a figurine to move on the mat. As I was saying earlier, there are between 5 and 10 proposed interviews. After that, depending on the situation, we can refer to the Violence Against Women unit of the hospital, or to specialized consultations on psychotraumatism, one for the 13 years olds, which welcomes children from the earliest age for early trauma, and the other for those over the age of 13. Yes, again, to professionals in liberal specialized on psychotraumatism. In France, the UAPED is the equivalent of the Barnahus centers and is deployed in each department. You can see on this map the UAPED already operating in orange, but also the green ones under restructuring where it is necessary to bring the minor UAMOs closer to the pediatric services. In light blue, you have those at the stage of project, and in navy blue, the projects to be finalized. There is also at the national level an association of forensic psychologists which aims to bring together and represent psychologists working in the major and minor UMUs and in the UAPED in metropolitan France and in the overseas departments and territories. It is also to promote psychology in the treatment of victims and perpetrators and also contribute to research, training, and information. This association, which is composed of all the psychologists working with UMG or UAPED in the hospitals, has organized in October 2022 a first colloquium about evaluation of the psychological impact in a criminal procedure. Thank you for your attention. I'm sorry I can't be here with you today. My contact details are available if you wish to get in touch with the UAPED of Orléans or if you have any questions.
So our thanks to Dr. Benoit for that wonderful presentation. Just to reiterate, if you have a particular question for her, please put your email address into the Q&A along with your question. We will get those questions to her so that she can respond to you via email. We will also be providing her email as well as all of the presenters' emails in the materials that you will receive after this presentation. So feel free to reach out to any of the presenters in the future as well. Our last presentation today is Enhancing the Multidisciplinary Response to Child Sex Trafficking. Please welcome Dr. Anish Raj. Dr. Raj has trained in pediatrics. This is going to be a long list. Pediatrics, psychiatry, child and adolescent psychiatry, and also child abuse pediatrics. He currently splits his clinical time between Wake Med Pediatric Primary Care and the Safe Child Advocacy Center, both located in North Carolina in the United States. His academic interests primarily revolve around domestic minor sex trafficking. He also serves as co-founder of the Adolescent Protection Collaborative, a specialized medical home for sex-trafficked youth in Philadelphia in the United States, where Dr. Raj did his training in child abuse pediatrics.
Awesome. Thank you so much, Kathy. And hello, ladies and gentlemen. Thank you all so much for being here. And a special thank you to the organizing committee for this wonderful webinar and this opportunity. It is an absolute honor to speak with you today about sex trafficking in the pediatric population and our roles and responsibilities in addressing this issue. Just by way of reintroduction, again, my name is Anish Raj, and I am a child abuse pediatrician at the Safe Child Children's Advocacy Center in Raleigh, North Carolina, in the United States. And I would like to go ahead and confirm that I have no financial disclosures or other conflicts of interest, but I do wish to acknowledge two foundations for their previous grant support of a specialized medical home for sex trafficked youth that I co-founded at the Children's Hospital of Philadelphia. Now, when people think about complex topics like sex trafficking, a lot of words can come to mind. And something that pops up in the media as well as the literature commonly are the notions that this population is invisible or hidden. And while the crimes involved in trafficking are often secretive and clandestine, I'm hoping that this session will demonstrate that these kids are reachable, do access care, and can meaningfully engage in their medical care as well as in investigative efforts. And what I think you'll see is that a lot of the vulnerabilities and challenges that are associated with involvement in trafficking are often tied to two primary themes: relationships and opportunities. Negative or the lack of relationships and opportunities that might contribute to involvement in the first place, and then positive relationships and accessible opportunities that may help support individuals as they might be trying to get out of the life. Now, as a jumping off point, I always like to start these presentations with a couple case vignettes. So what I'd like to do is just flash up a case vignette on the left side of the screen. I'll give you guys a moment to think about it, and then flash a different case vignette on the right side of the screen, and then we'll discuss. This first one is a 3-year-old female being evaluated in a child abuse clinic or a children's advocacy center for a question of sexual abuse perpetrated by her 13-year-old stepbrother. Patient is briefly interviewed and responds, quote, "Yes," when queried if the alleged perpetrator scares her. She further states that, quote, "I don't want to lay down with him." For any of us that work in this field and specifically work with children, I imagine that this is the kid that, invariably evokes empathy, the kid that we want to protect, the kid that we want to keep safe. perhaps the kid that brought us into this field in the first place so that we could continue to serve children that have been through similar experiences. But I'm going to have you pause on this case vignette while I flash up the other one really quickly. Now we have a 15-year-old female in the emergency department brought in by law enforcement, acutely intoxicated after being found in the back of a parked vehicle with an unknown adult male. This patient is noted to be, quote, crying and screaming and refused to engage, stating that I'm going through my own stuff. She declines all offered services. Now, for those of us that have worked in hospitals or other clinical settings, this patient invariably comes in the middle of the night, towards the end of our shift when we're trying to catch up and perhaps leave work to go home to our family. And I think I can speak for all of us when I can acknowledge that these are often very challenging in knowing what to do, very challenging because we're already stressed about the other patients that we might have to see, and then very challenging in the sense that these patients aren't seeking help in the traditional sense. But the reason I bring up these case vignettes is actually to highlight that this is actually the same child. This is a patient that I had the privilege of taking care of in a previous line of work, and it's actually the same child, just 12 years apart. And as you can imagine, life wasn't entirely kind to her in those 12 years. And this is just to remind all of us on this call, on this webinar, but also to remind myself that we're always seeing these kids at various points in time. There are so much that goes into their daily life experiences that we may never be aware of, never be privy to. And so to ensure that we empathize with all of these children and try to do our best to provide the services and care that they warrant and deserve, regardless of how they might be coming in, even if they're coming in a point of crisis. Now, while the experience of trafficking is often unique, both within countries, but especially internationally, and it's often heterogeneous, so in other words, it's different for every individual, it can be helpful to conceptualize the stages of caring for victims and survivors of trafficking as initial identification, stabilization, recovery, and reintegration. And I just want to note that this graphic does not acknowledge prevention efforts, which of course may mitigate or eliminate trafficking involvement in the first place. Now, while on paper, these stages seem to follow chronologically, so going in order, please know that in real life, the process is often non-linear. So individuals may take a step in one direction, then be pulled back in another direction. And I think most of us who work in this field would argue that non-linear engagement, so not straightforward, engagement in care is usually the rule rather than the exception. In other words, caring for this population tends to be a marathon and not a sprint, which is counterintuitive to what we usually think of when it comes to trafficking. So before we dive in, I recognize that terminology around trafficking is not universal, certainly not internationally. So I want to quickly establish a common language for the purposes of this presentation in particular. A phrase you may see mentioned often in medical literature published in the United States is the commercial sexual exploitation of children. Now, I recognize that that's a mouthful, so it's a lot of words, so we often just break that down to calling it CSEC. So the commercial sexual exploitation of children, also known as CSEC, this is the overarching umbrella term that includes both international and domestic minor sex trafficking, as well as numerous other forms of sexual exploitation. It is broadly defined as, quote, any exchange of a sex act for goods, and goods can be money, shelter, drugs, anything of value involving a minor, which I think we all define as someone under the age of 18. Now, under CSEC, domestic minor sex trafficking, or DMST, is a subset. It more specifically refers to CSEC that involves a U.S. citizen or permanent resident within the borders of the United States. Those two qualifiers are what distinguish DMST from other forms of CSEC. And contrary to popular belief, trafficking does not require the movement or transportation of a victim. People can be trafficked in their own homes, on their own block or neighborhood, as well as across state lines or international borders. Now let's establish what research has shown about sex trafficking in the United States. And I do want to note that literature and research on this topic, in particular in the United States, is relatively new. It's really blown up in about the last 10 to 15 years. So please note that, these numbers, the information that we're sharing is constantly changing, constantly evolving. But firstly, federal laws have been passed that recognize that individuals who have been trafficked as victims who have been trafficked should be identified as victims of crime who warrant specialized services. I recognize that not every country that is represented, based on the attendees on this call, share the same legislation. So I encourage you all to become familiar with the rules, regulations, and laws that govern the provision in addressing trafficking in your own respective countries. And so what we know about trafficking in the US is that numerous studies have determined that the vast majority of minor sex trafficking victims here in the United States are actually quote unquote American kids. In contrast, while I cannot, again, speak for each of your respective locations, my understanding is that European statistics tend to skew towards higher rates of international sex trafficking, so meaning across international borders. Another myth is something that we often see sensationalized on television or on Hollywood movies, and that's this idea that trafficking usually involves a person getting abducted or kidnapped and introduced to the sex industry. Now, again, while this can happen, it's actually relatively rare. It's far more common for traffickers to psychologically manipulate their victims. And then there's also growing evidence that face-to-face interactions in social settings, like at parties or in group homes, and peer recruitment can play a large role in initial recruitment. Another reality is that all genders are affected. So that's boys, girls, cis, trans, non-binary individuals. And while our society typically only portrays victims as girls, research shows that a significant number of boys are also being trafficked, but that we're not doing a great job of identifying them. There have been some pretty large studies on male victims in New York as well as London that show that it is a pretty sizable minority. But as we all know, boys as victims of sexual violence tend to fly under the radar. It's also important to recognize that while most traffickers are indeed men, women can also play roles in exploitation. However, there's one clear area where there's a clear gender distinction, and that's when it comes to demand or the buying of sex. Virtually all purchasers of sex, especially in the United States, but internationally as well, are adult men. And I think that statistic should make us all uncomfortable and really speaks to the social accountability that is needed when it comes to our universal response to trafficking. What we can also confidently say is that cases have been reported in every state throughout the United States. But the truth is, there's no one set profile for who might be or is a trafficking victim or survivor. Any child or adolescent is technically at risk. It doesn't matter where they live. Rural, urban, suburban communities are all affected. Doesn't matter who their parents are, if they live in a group home. Victimization also tends to transcend race, gender, and sexual orientation. But what we can do here today is explore some of the underlying exposures and vulnerabilities that can be associated with trafficking involvement. And while not all of these will overlap with the experiences of the patients that you might take care of in other countries, I suspect that many of them will. But before we jump forward to the individual, we need to take a step back and look at the big picture. Nothing happens in a vacuum, and it's not possible to address or respond to trafficking without thinking about these other pieces. What research has shown us is that involvement in trafficking is inherently difficult to separate from poverty, household dysfunction, and systematic oppression. And preliminary data that's been aggregated over the last few years suggests that the COVID pandemic only further exacerbated this discrepancy. This slide is arguably what I consider to be the overarching theme of this presentation. From a societal and community standpoint, I think it's super duper important. It's really important that we consider the messages that are being communicated to our young people about their bodies, about sex, about consent, and then also reflecting on the opportunities that young people have based on where they grow up and the people that they interface with. We have to think about the employment landscape, the availability of social supports, the exposure to potential violence in the community, as well as the school systems and the educational opportunities that a kid might have. And only after some of these considerations can we bring it closer to the household and the individual. Now, the strongest correlate that has been seen in study after study from an individual risk factor standpoint is a history of childhood sexual abuse. And I mean prior to being trafficked. We should all be aware of how childhood sexual abuse affects people long term, not only when it comes to their own self-image, but also in terms of boundaries and relationships with others. Next, we can look at background environmental factors. This usually implies some sort of household or social dysfunction. Families that are abusive, neglectful, dealing with their own substance use issues, maybe have child welfare, child protective involvement for one reason or another. Youth homelessness is also certainly a risk factor. And then another risk factor, as we have alluded to before, is a kid social circle. So that can be deeply influential when it comes to peer recruitment, which is something that we're learning more and more about in the United States, where individuals who might be involved themselves also reach out to either peers or friends and kind of invite them in as well. Now, the intersection point where a personal history of trauma and baseline household or social dysfunction can sometimes, but not always, can always meet and result in trafficking involvement is running away. It's a combination of intrinsic and extrinsic vulnerabilities coming together, if you will. But I do want to emphasize, a particular kid may have all or none of these risk factors and still be involved or not be involved. We don't know enough yet to assume one way or the other. And it's important that on our eagerness, our real desire to help children and identify them, we don't start labeling them because that can be detrimental in a different way. From a healthcare standpoint, studies confirm that trafficked youth are at higher risk for negative health outcomes across the board. So that includes higher rates of sexually transmitted infections, or STDs or STIs, unintended pregnancies, higher rates of mental health diagnoses, as well as increased rates of adverse childhood experiences. However, given the inherent safety risk and transient nature of trafficking, access to consistent medical care is not always feasible. If we only focus and fixate just on the trafficking aspect, we might forget that the individual in front of us has a chronic condition like asthma or diabetes and may not have ready access to their inhaler for their asthma or their insulin for their diabetes when they need it. So acute exacerbations of their chronic condition may present with more severity or complication when they actually do end up coming to an emergency department or urgent care. Now, specifically when it comes to mental health, it raises this question of, is the trauma associated with commercial sex, so trafficking, especially the frequency and the number of perpetrators, different than the trauma of non-commercial sexual abuse? And preliminary data suggests that the answer is yes. Trafficked youth have been shown to have higher rates of anxiety, higher rates of depression, higher rates of substance use, as well as higher rates of post-traumatic stress disorder or PTSD. And especially when it comes to PTSD, the symptoms of avoidance, re-experiencing, so like nightmares or flashbacks, and hyperarousal, so that vigilant aspect, have consistently been found to be higher. For anyone that's worked in a crisis center, it probably doesn't surprise you that these kids also tend to exhibit higher rates of externalizing or acting out behaviors. And so that can certainly present as behavioral challenges in an acute moment. But I think that makes sense. And so this is admittedly a simplified model. I'm certainly not a neuroscientist, but I think it gives us all some food for thought. Keep in mind that we're talking about adolescents here. So teenagers, usually somewhere in the 14 to 16 years range. So let's start with the left side of this model. Hopefully all of us are here on Tuesday morning, afternoon, wherever you are, resting, learning in what we might consider to be a calm state of mind, or as calm as a Tuesday can be. That generally translates to a higher level of brain functioning using the neocortex. It allows us to think abstractly, organize ourselves, problem solve. It also helps us to be future oriented. You might be listening to me, but also thinking about picking up your kids later today, thinking about this paper that you want to write, thinking about the 5-year plan, the 10-year plan. You might be doing all of those things simultaneously. You might be able to multitask because you're in a calm state of mind and able to use your neocortex. Conversely, if we flip all the way over to the right, I want everyone to think about a time that they were terrified. And I mean truly, truly scared, fearful. In that moment, you were likely relying on primitive reflexes that are born out of the brainstem. We think of this as colloquial survival mode, fight or flight. And at that moment, your brain probably wasn't thinking about later in the day, later in your future. It was focused on the here and now. But the take-home point of this slide is actually the states in between those two extremes. I would argue that many trafficked youth, so a lot of the kids that we're talking about today, especially with histories of trauma, spend a lot of their lives in these states of alert and alarm. Certainly when they're interfacing with authority figures like Child Protective Services, law enforcement, juvenile justice, and the healthcare system. I think sometimes for a lot of us as medical providers, we forget that, we're trying to be compassionate and trauma informed, but to a kid that's never met us before, we are still an authority figure. And with that can come certain levels of vigilance and fear. And so it makes sense that the brains of these kids rely on these areas that correspond with heightened alertness and more concreteness. And it's not surprising that connecting the dots, sometimes between point A and point B, and planning for the future can be challenging for them. Because in those moments, their brain is really just focused on getting through these next few minutes, the next few hours, not years down the line. So what may seem so obvious to us may not actually be so obvious to them, depending on where their head's at that time. So now you might be thinking, hey, what do I do if I have a kid that I'm worried about? And how do I meet them where they're at? And to help answer that question, multiple qualitative surveys have looked at what survivors want from providers. And what's striking is that while we as providers tend to report discomfort due to a perceived lack of training, what kids want from us is actually fairly simple. They do not expect us to know the intricacies, the complexities of the sex trade, or even life out on the streets. They really just want us to treat them like we treat everyone else. And that starts with really listening and not simply just labeling someone a victim. Encouraging them without resorting to, you should do this or you should do that statements that really come off paternalistic or maternalistic. Encouraging them and getting to really understand their circumstances, why maybe they've made some of the decisions that they have, and then not judging them. And this one's the biggie. Nothing has been reported to erode or really mess up a kid's trust in their provider more than feeling judged. And last but not least, sticking around. A lot of these kids have been failed again and again by adults in their life, the systems in their life that are meant to protect them. And so we need to be reliable and not walk away even when they might push and test some of those boundaries. Now, speaking of what these kids need, let's switch gears and talk about the next stages in the pathway of care: stabilization, recovery, and community integration. In practice, the reality is that given the mandated reported requirements in the United States and how the system functions at this time, this process is usually kickstarted by Child Protective Services and law enforcement as they become involved. When there is a cause to suspect or knowledge of a trafficking situation involving a minor, so someone under the age of 18, in most states in the United States, reports must be filed to Child Protective Services and then also police reports to law enforcement. An investigation will be initiated, and many of those youths will be forensically interviewed at a Children's Advocacy Center or a CAC. I think this opportunity to bring all the different parties together to share perspectives and make sure everyone is on the same page can be really beneficial. I think that's how we've seen it come out in clinical practice. Oftentimes, the way that law enforcement has been trained on these topics is quite different from how we have from a trauma-informed or medical standpoint. Their efforts, their goals to ensure a successful investigation and prosecution may not always align with what we think is best for this patient and for their care and their needs in this moment. I also want to take a quick digression and note that international or transnational trafficking cases usually have additional complexities. So that's related to legal immigration status. There are some, but admittedly limited visa options for trafficking survivors, including the T visa for victims who are physically present in the United States. So they were brought to the United States on account of trafficking or for trafficking purposes. And then there's also the U visa for victims of crime. My understanding is that European countries tend to have their own versions of these, but depending on, any given day, I think these things are in flux. So I think it is helpful to continue to stay familiar with any changes that might be made to these processes. Now, as you've heard from our wonderful previous presenters, the primary goals of the CAC or Barnahus models are to improve criminal justice outcomes while also reducing the number of times a kid has to talk about their experience to different individuals, and also help link them with support services that will be helpful moving forward. Now, when we talk about the CAC response, there are some published recommendations that include incorporating sex trafficking questionnaires into the intake process. Unfortunately, while this makes sense intuitively to all of us, the reality is that we're still waiting on more accurate, generalizable screening tools. The screening questionnaires that are currently in practice tend to have low specificity and low positive predictive values. And none of them have truly been validated in a CAC setting. So we're still trying to come up with something that would be a good fit for that setting. Forensic interviews might also benefit from adding prompts to their protocols that specifically help clarify circumstances related to the trafficking experience. Again, our forensic interviewers are already well trained in asking open-ended questions and developmentally appropriate questions about sexual abuse, sexual assault. It can be helpful just to add a few more prompts to clarify some of the uniqueness of a trafficking circumstance or situation. Um, but regardless, studies suggest that the majority of kids won't disclose, especially initially, especially after just one time of meeting you. And we need to be aware that fear is a significant barrier. Fear of the system, fear of the trafficker, fear of the unknown. And so some of those things that we might take for granted in other patients, such as safety, privacy, confidentiality, might need to be explicitly verbalized and shouldn't be assumed because this kid, when they're coming in, have so many other thoughts in their mind, they might not be aware of what is considered to be confidential, how they're protected in terms of what they're disclosing or sharing with you. And again, as I mentioned before, it can seem counterintuitive, but we're often playing the long game here. Sometimes this requires multiple interviews, sometimes it requires taking some time to develop rapport, maybe having kids continue to present and develop a longitudinal relationship or therapeutic alliance. And I think that's what a lot of providers who might not have a ton of experience with this population struggle with. Again, that this is a marathon and not a sprint. So meeting these kids where they're at is key. And it really goes back to these notions of autonomy and empowerment, which trafficking is truly the opposite of. Trafficking really takes away someone's autonomy, really disempowers them. So we're trying to provide care that restores those concepts to them. And I've actually had patients tell me that the most helpful thing that I could do for them was to limit and streamline the number of services and appointments that they had because it was all too overwhelming at that time. So flexibility, again, is key, and it's huge. And in our eagerness to intervene, we can't forget that for many of these kids, talking about their experience and talking about the investigation or prosecuting someone who is being held accountable might not be their priority in that moment. They might have other care needs. They might be trying to find a safe place to live. They might be trying to get back into school. They might be dealing with anxiety, depression, acute suicidality. So we might be jumping the gun if we force our agenda on them when they come seeking care from us. So I think it's really important to keep our eyes and ears open and try to help kids based on their own needs and their expressed needs and preferences. But if there is one thing that you take away from this presentation, I hope it's that no individual or even organization can meet all of the different aftercare needs that trafficked kids need, that trafficked youth need. It truly takes a village, and each sector or domain is just one piece of the puzzle. Having worked with law enforcement in the past, so special victims units, I can tell you that these investigations are incredibly challenging, incredibly time consuming, and often even harder to prosecute. So quote unquote justice in the traditional sense can be difficult to achieve. I know Dr. Fars had mentioned this. I think we have um, a lot of television shows, a lot of movies here in the United States and internationally that seem to think that, once someone says what happened to them, the offender or the trafficker is held responsible. And I think the reality is that's unfortunately not often the case. I think, again, these investigations often takes months, if not years, sometimes stretching into decades. And so, I think being aware of what realistic expectations are from a judicial or legal standpoint can help set our expectations. And I think more so knowing that makes the provision of what we're doing, so the support services, the facilitation of educational opportunities, healthcare, even more important because we can't guarantee what's going to happen on the other side, but we can be there with the patient in real time. So prior research has shown that following identification or even suspected identification of someone who might be being trafficked, kids in the US are referred to an average of 3 distinct agencies for ongoing care. So that can definitely and easily lead to fragmented care. So it can be helpful to have a central coordinator at an intersection point in the system like a CAC or Barnahus to be a designated navigator to coordinate services across organizations. Now, when it comes to rehabilitation and reintegration, there unfortunately is no single generalizable solution. Each individual circumstances are unique, and as we've noted before, the barriers or issues that were present before that may have contributed trafficking involvement, unfortunately, are probably still there. So while there's been an understandable emphasis on identification in the past decade, and that itself remains a work in progress, as we mentioned with the screening questionnaires, there's arguably even more work to be done when it comes to maximizing aftercare. So what we do or what we can provide individuals after they've already been identified. And this is some of the most meaningful, rewarding, and just, honestly, plain fun aspects of the work. Because we've learned that at the end of the day, it likely comes back to human connection. Studies have shown that survivors almost never cite a specific treatment modality when it comes to their mental health, but rather the support that they perceive from their family, their providers, or even other supportive people in society as being the most important during the period of rehabilitation and reintegration. I've heard survivors say that the emotional pain that they experienced when they were trying to re-enter mainstream society with all the stigma, how people judge them, the preconceived notions, was worse than anything that they experienced while they were being trafficked, which is horrible, and really unfortunate because it really feels like that's something that we can contribute to collectively changing. Welcoming people, helping, supporting them, not judging them, being present with them is something that I think is in all of our wheelhouses. And I also want to quickly acknowledge these two small studies about 10 years apart. The initial one was in 2014. The other one was came out just last year that looked at variables that differentiated whose exploitation or trafficking experience persisted from their teenage years, so in adolescence, into adulthood, versus those who got out of the life or out of their trafficking situation earlier. And it found that completion of high school education was crucial. Finishing high school, as we all know, can open up doors and opportunities that are often not available to those who have disengaged or dropped out of high school. And anecdotally, or anecdata as we like to say, supports that individuals who drop out can often get funneled, unfortunately, into lower paying jobs in the service industry that may not feel meaningful, may not pay a livable wage, and can even often replicate the dynamics of trafficking. So, for example, where jobs where someone is asked to dress a certain way or act more forward toward customers, and that's tied to their job performance or higher tips, that can actually replicate some of those trafficking dynamics. So we have to be aware of those. And while we're still in the early stages of determining the needs of the kids in this population in North Carolina, where I currently practice, and our surrounding areas, I do want to quickly highlight an example that I think worked well when I worked up in Philadelphia. In 2021, I had the incredible privilege of helping launch the Adolescent Protection Collaborative, or the APC clinic, at the Children's Hospital of Philadelphia. And it continues to serve as a specialized medical home for sex trafficked youth and offers co-located same-day care by a member of the child abuse group, adolescent medicine, and social work. It's housed within a primary care setting so that there is access to quote unquote regular or traditional pediatric care. And while we collaborated and partnered closely with the local CAC in Philadelphia, our clinic site was actually separate. And if anyone has any questions why we did that, I'm happy to answer those in the Q&A or by email. But there were specific strategic reasons to keep those things separate, to make sure that we had a safe, non-legal, non-investigated space that was specifically for the kids and that they knew wouldn't kind of interface with some of those other aspects when they wanted to come seek medical care on their own terms. And over the first 21 months, or roughly 2 years of clinical operations, almost all of our referrals identified as females. Patients range from age 13 to 22 with an average age of 16 years, and the vast majority identified as minority race or ethnicity. None of our kids lived in households with both of their biological parents. All of them had child welfare involvement. So just thinking about some of the socioeconomic factors that might be contributing. And then the vast majority came to appointments on their own, not accompanied by a caregiver. Almost all were on state public insurance, and 100% also had some interface with the mental health system. In addition to in-person clinic visits and follow-up, telephone outreach was actually super duper helpful in helping stay in touch. As you can imagine, just given the experiences of trafficked youth, there are times where they're able to come to clinic every few weeks or months, and then there's times where they seem to go off the radar. So telephone outreach, so calling, texting, staying in touch that way was actually very helpful. And we actually had numerous points of contact just from a telephone outreach or correspondence standpoint. Now, research in recent years has really demonstrated that so much of people's outcomes and their health is mostly influenced by things outside of healthcare. It's estimated, this is a pretty neat study on the left, it's estimated that healthcare, like actual clinical care that we provide, really only contributes to about 20% of an individual's overall health, whereas the other 80% is contingent on socioeconomic factors, decisions that they make, other aspects of their world, their support systems, their community, and all of those things. So with that in mind, in conjunction or along with the more traditional healthcare that we were providing in our clinic, we also made really intentional or concerted efforts to address social care at the same time that we were covering their traditional medical needs. And so this included some of the more standard referrals to other healthcare providers. So if someone needed a dentist or a psychiatrist or, a lung doctor or something like that, but also things like assistance with securing a formal city identification card. A lot of our kids didn't have any form of identification or ID, so they had a hard time accessing different services in the community. But if we were able to help facilitate some of that, they could at least, be able to access some of those things that they might not have had before. We also partnered with an alternative educational program through the local community college that helped support kids who had disengaged from school. And our hope was that over time, those would be the linkages that would really open doors for our kids. Overall, I would say we were very encouraged by the attendance and follow-up rates, as well as the work that we were able to do to optimize the sexual reproductive health of our patient. But what really felt the most meaningful was creating a safe clinical space where kids could come in, be themselves, be supported unconditionally and with no agenda, and then get their needs met on their own terms, which again, I think so many people voiced that they had never had that experience before, unfortunately. But again, if you remember nothing else from today, just know that none of us are in this alone. It truly takes a village. It truly takes a team effort. People, and especially these kids, need a lot more than what we're typically offering in the modern medical or forensic models that we all work in. And I think it's important that all of us go back to our respective facilities and institutions and critically evaluate the services that we're offering and what interventions we can facilitate to have maximal impact on the whole person. And depending on where you live and practice, it can be really helpful to familiarize yourself with the community organizations that serve this population. They may be able to help fill some of the gaps that you or your clinical setting might not be able to. So if you work at a Barnahus, you don't have to have access to all of the services or resources housed within your site, but you might be able to partner with other agencies or organizations that might be able to provide things that you're unable to do or you're not staffed to do. But first and foremost, I do think it's important that all of us, especially because this is an international audience, go back and just review what the current rules and regulations and laws are for trafficking in the pediatric population in your region or your area, because that will really dictate or change the amount of work or the different types of work that you're able to do and the care that you're able to provide these kids. I also just want to acknowledge that, guys, we do have positive outcomes. I've seen so many positive outcomes, and it really is just an awesome, awesome thing to be a part of. This is a patient who previously was treated for 5 STIs, so 5 STDs over a couple years, had been in 3 different placements, was no longer with their biological family, was no longer with their adoptive family, but was actually in a separate placement, had repeated 9th grade, so the first year of high school 3 times, had persevered, had pushed through, and then emailed me actually about a year ago, so last summer, that she was going to prom and graduating high school. And for those of you who live outside the United States, just know that prom is a big deal in American high schools. You might have seen it in many Hollywood movies. It's considered a rite of passage. And so this is something that she was really excited about. And yeah, and she's doing great. And if you would have surveyed someone a few years ago and asked them whether, this kid would be here today and doing so well, I think most people, unfortunately, probably would have said it's unlikely. But this is how we overcome statistics. And it really takes a lot of effort, but it's really meaningful work. So thank you guys so much for your attention. And I will stop sharing so that we can get to the Q&A.
Great, thank you so much. And what a lovely way to end. So thank you. I'm going to ask all of our panelists to turn on their cameras, but unfortunately, we really don't have much time for questions. But there was one question that came in that I was going to ask all the panelists, and that was about what you do about secondary trauma, which is such an important part of the work that we do. And so I'm going to ask Jane to share a slide about, and this was not a plant or anything, but there is a ISPCAN webinar later this month. And here's the information here. And Gabby or Jane, if you want to add anything to this slide, anything about it, but please have this information. We will send this out as well as all of the other information as well. And I think I'm going to ask Joanne one quick question. I know that Karen had answered a lot of questions in the chat. We will get a lot of that to you as well. So the question for Joanne, and Joanne, you have about a minute to answer this. The average time from the opening to the closing of a case in the Barnahus in Galway, and has the opening of Barnahus accelerated court proceedings, so made that process a little bit faster?
Yeah, I'll answer the second question. We don't have the data as yet because the Barnahus has only really been going since 2020. So our criminal proceedings take a long time. The average for a case to come to court would be 2 to 3 years, although there is a recent mandate by the government to have the court proceedings happen within 6 months of a disclosure. So we'll have that data, I hope, over the course of the next few years. Now, remind me of the first question. Oh, how long does a case
take to get
from
through?
Beginning to end? That is hugely variable. So a case might be finished within a matter of months. So I'm guessing that the average might be 6 months, 4 to 6 months, but some children will have longer therapeutic needs and will stay engaged with the Barnahus for up to a year, perhaps even longer. And then the practice is that although the case is closed to Barnahus, if the child has needs that can be supported again within the Barnahus, they can be referred back for the therapeutic support around that. Okay. But it is hugely variable.
Wonderful. Okay, before I send this back to Gabby for one more announcement and a goodbye, just a reminder: if you had a question, we obviously didn't get to really any of them. You will have the speakers' emails. Please feel free to send your question to them via email. And then I will hand it over to Gabby to say goodbye to all of us.
Yeah, thank you. We'd like to extend our heartfelt thanks to our wonderful speakers for sharing their time, expertise, and insights. I hope you all appreciate how and have gotten a taste with the Petit for appetizers for what is in store in Paris. A special thanks to Jane Estes at ISPCAN and Catherine Torcel at we.se, that's our conference organizer, whose dedication and behind the scenes work made this webinar possible. And we're deeply grateful for your support. So again, we're looking forward to continuing this conversation. Please stay engaged, and we hope to see many of you at INTERCAP in Paris in May 2026.
All right. Goodbye, everyone. Thank you all for joining and for presenting.